So welcome everyone, welcome to my channel. Okay, this is a live section on PCOS with Dr. Henry, an obstetrician and a gynecologist. Okay, about the questions I've been having, a lot of questions. I told you guys my specialty, which is the renal nurse. So if there are questions you ask me and I don't know them, I just have to, or I don't really know them very well, okay, I just have to meet the consultant. Okay, so please listen attentively. This person is a consultant, okay, in gynecologist, and he is very good. Trust me, he is very good. You will learn a lot about this question. So in this video, we'll be talking about causes of PCOS. Okay, can you cause PCOS as a woman? Can a woman cause PCOS for herself? Is it possible to get pregnant with PCOS, and how? Factors that may increase your chances of getting PCOS, management of PCOS, how to live, how to manage PCOS, and what happens if you don't manage PCOS, what will happen over a long time, and the complications are serious complications. Okay, and types or kinds of PCOS. Many people don't know that PCOS have different types, so they keep treating what they don't know. Okay, so just listen and listen good. Okay, symptoms that might suggest that you have PCOS, and how they make this diagnosis. Okay, just listen, don't skip at if every point you don't understand, just listen. Maybe the next part you will understand. Okay, so let's get to it. Please, if this is your first time of joining me here, like, you will learn a lot of things in this channel, not only about women, about health, different kinds of things, about kidneys. Okay, so let's get to it, guys.
Okay.
Hi everyone. Please meet Dr. Henry. Dr. Henry, please say hi.
Yes. Good evening, everyone. My name is Dr. Henry. I'm the consultant obstetrician and gynecologist. You're welcome to this program.
Thank you, everyone. So today we'll be talking about PCOS. You guys have been asking me lots of questions, like lots and lots of questions about PCOS. I do want to answer the ones I can, but then I take some of these questions down for the professional in this field, which is Dr. Henry. So we're going to be tackling some questions about PCOS. So Dr. Henry, please, I would like to ask, is hormonal imbalance the same thing as PCOS?
Okay. First of all, PCOS means polycystic ovarian syndrome. Yes, it's a condition, it's an entity in gynecology. While hormonal imbalance means your hormones, or a woman's hormones, are not optimal. Yes, because every hormone in a woman has an optimal level, has a normal level that is supposed to be. So for those that have either a lower level or a higher level, they are regarded as having hormonal imbalance. So the two are not the same. Why PCOS has hormonal imbalance as one of the major problems in PCOS, but hormonal imbalance is not the same thing as PCOS. No.
So guys, you see, we're getting it all wrong all this while. Yeah. Most women think they have PCOS and therefore they must have hormonal imbalance, or they have hormonal imbalance, which means they have PCOS. Yeah. So Dr. Henry here says they are not the same.
Yes,
okay.
Yes.
Okay, so the second question is this: do anyone do anything to cause PCOS? Like, can a woman cause PCOS for herself? Okay. Because most women are, sad, thinking that they are the cause of this particular thing.
Okay, thank you for that question.
Yes.
Today, PCOS, the prevalence of PCOS in today's world is getting higher and higher. The condition is becoming commoner in our society, unlike in the past, where you see PCOS once in a while. So the question is, does women do anything to actually cause this condition? The answer is no. Up till today, science have shown that the cause of PCOS is unknown. Yes, the actual cause has not been identified. Up till today, science have not been able to identify the cause of PCOS.
No woman can cause PCOS for herself?
No. A woman does not contribute to her development of PCOS. No.
Because most husbands feel that their wife not getting a child is as a result of the woman, because the woman has been diagnosed of PCOS. So they think the lady is the cause of the PCOS. Probably she must have done something in the past, and the lady is not happy about it, thinking that she's actually the person causing this thing for herself and her family. So guys, you've heard it. You're not the cause of this condition. You're not the cause of PCOS. So stop feeling guilty about it.
And you did nothing to contribute to the development of PCOS. No. It is, yes, you have no hand in it. It just occurs into some people for reasons I'm going to mention later in the discourse.
So, okay, please.
Okay, so I said genetic factors, okay, interacting with environmental factors have been found to, increase the risk of this. Yes. Other ones are metabolic factors, because these people have been found to have some level of insulin resistance. These patients or these people that have developed this condition usually have some level of insulin resistance, which means the normal level of insulin that controls blood sugar in normal individuals, you understand, cannot control their own blood sugar. They require higher level of insulin. So when you check them, you find they have what they call high insulin level. Yes, because they have increased insulin resistance, means their ability to respond to insulin is reduced compared to the general public. So these are all the factors that play together to now give rise to this condition. But you can bear with me, the most important thing is that all these factors have the patient that developed this condition does not have any control over these factors. That's the bottom line. But these factors play together to give rise to the condition.
All right, guys. So you can see
genetic, environmental, and metabolic factors.
You said that you didn't do anything to cause this thing, but there's no known factor. There's no known cause of PCOS. However, there are factors that might increase your chances of getting PCOS, which is genetic, running in the family, environmental, kind of things, sedentary lifestyle, you don't control what you eat, and then insulin resistance,
metabolic factors,
and other body factors. So, thank you, Dr. Henry. Please, let's just move forward. Can we talk about very important one? Can a woman get pregnant with PCOS? Because most women are asking me this question. They say, there are lots of they say outside of this. They say women cannot get pregnant with PCOS. Please, can you explain?
Okay. First of all, categorically, let me state this fact. People with PCOS can get pregnant. That should sink very well. Now, why some will require assistance in order to get pregnant?
What do you mean by assistance?
Assistance means medical intervention, either by ovulation induction, IVF, that means in vitro fertilization of fetuses, that is getting pregnant outside and then transferring to the world. Everybody knows what IVF is now, it's very common. Or some will require what they call surrogacy. But everything depends on other factors. The most important is that they can take in. Some of them can take it spontaneously without any help, while some will need help. But the bottom line is that they can get help. Okay, so these are some of the things a woman will observe, especially when they are associated with irregular periods or inability to conceive. Then, of course, you should go to your doctor for proper evaluation to find out whether you have PCOS. So when you now come to us, it is now our duty to examine, to first of all get a detailed history from you, confirming some of these things, and then now carry out physical examination on our own to also find out whether this condition. So some of the findings that may suggest PCOS includes
from your part.
Yes, from our part. Yes, a body mass index. Body mass index is when we take your weight and take your height and then divide your weight by your height square, where there's a level. Any BMI that is more than 25 to 29 is overweight. And then BMI that is 30 and above is obesity. So most patients, you see that they have a BMI that is more than 25, which is either overweight or obesity. That's number one. Two, we can see evidence of hyperandrogenism, which is high level of estrogen, high level of testosterone, which is male hormone in these females. Yes. And how do we know that? When we begin to see those hairs, it shows, without even doing a hormonal profile, that this person might have an elevated level of male hormones. Okay. Then other things include now things that could suggest complications, because sometimes these women may have some problem as a result of their hormonal imbalance, and they include things like, for long-time cases, congenital heart diseases, coronary artery diseases, dyslipidemia, which we see on history, which you see on investigations. But all that generally, are seen now and further when you evaluate the patient further.
So guys, Dr. Henry said something right here. He said symptoms, right?
Yes.
That you will see that may be or might suggest PCOS.
Yes.
Which you don't take that decision that you have PCOS. When you see this thing, you go to the doctor will now evaluate you and make the diagnosis, which are the overweight, right?
Yes.
Irregular menses, having hairs when men are supposed to have hairs, like having hairs in your chest,
mustache, sideburns,
all of those things, and then trying to get pregnant without success. When you have these signs, don't assume that you have PCOS until you meet the experts, okay? So I hope that you get this point. So you're talking about diagnosis, like when you guys diagnose or ascertain that a woman has PCOS, how is it diagnosed?
Okay, so I just mentioned that you use history, examination, and investigation. But these three components put together, there is a consensus committee that develops a criteria for this diagnosis, and they use three major criteria. Criteria number one is irregular menses and/or anovulation.
What is
anovulation? Means the woman that is not ovulating. Now, that time, I think, remember when you want to check order. If you see your woman and you want to see you're not ovulating, that's number one. Number two set criteria is clinical or biochemical evidence of hyperandrogenism. Simply put, any evidence, whether it is clinical or biochemical, that shows that you have high male hormone level. I've just mentioned some of them.
Yes.
Then the third one is polycystic ovaries on ultrasound. They check your ultrasound, they found out that you have polycystic ovaries arranged in a particular pattern that is seen on PCOS, or your ovarian volume greater than 10 centimeter cube. Yes, it's either the number of cysts or the entire volume is greater than. So if you have two out of these three criteria, you are qualified to be said to have this condition. Yes, if you have two out of these three. Now, based on this criteria, we now have 4 different types of PCOS. I don't know whether you may want to know about that.
Okay, 4 different types.
4 different clinical presentation or 4 different clinical phenotypes. Simply means 4 different modes of presentation.
Okay, please tell us about that.
Okay, so the first one is called the classical PCOS. Classical PCOS has all the 3 criteria I just mentioned: irregular menses, signs of hyperandrogenism, and polycystic ovaries.
Please hold on, please, you know, the English is getting
too much.
Yes, please. Are you saying that PCOS has types?
Yes, 4 different modes of presentation, or 4 different kinds you can see in the
So guys, you can see that your friend has PCOS, and probably because most of you do this, you're taking your friend's drug. Your friend tells you she's taking this drug. Doctor says she has PCOS and she's taking these drugs. You too, you think you have PCOS, or probably a doctor has diagnosed you having PCOS. You go on and you're taking prescription from your friend that has PCOS. Because most people say, I have PCOS, come let me give you drugs. I'm taking the drug. So you see, PCOS has different kinds. So the one your friends might have might not be the one you have. So please take this, is very important. So guys, you can see that PCOS has types, kinds of PCOS. The one your friend has might not be the one you have, and yours might even be easy to treat or whatever it is. Please let's hear from Dr. Henry the kinds or the presentation of PCOS and how to manage them.
Yes, so the first clinical presentation is called classical PCOS. Those ones have the 3 criteria I mentioned: irregular menses, high male hormone level, and then polycystic ovaries when you check on ultrasound. The second one is called non-hyperandrogenic PCOS. Don't forget about the big name. What that means is that it's a type of PCOS whereby you don't normal male hormone level. So those people, you may not see them with all these hairs and all that. Yes, yes, but they still have PCOS. Yes. So to show you that it's not everybody that has PCOS has hirsutism, they have all this mustache and all that. Yes, you may not see.
What about pimples?
Pimples are part of high insulin level, high testosterone level, high male hormone level. Yes, it is the male hormone level that causes the pimples, that causes the hairs. It's called acne, and all of that are part of hyperandrogenism. So remember, the second one is called non-hyperandrogenic PCOS.
Where you don't see all this.
Where you don't see exactly, yes, but the person has it, yes. And then the third one is called the ovulatory PCOS. In this particular one, they have they have every other, the second and third one. That is, they have clinical evidence of hyperandrogenism. They have polycystic ovaries, but they don't have irregular menses. And they are ovulating normally. In fact, this group of people, they don't even know that they have PCOS until maybe you just want to scan a woman that is pregnant, maybe for one reason or the other, and you notice that the ovaries have a lot of cysts. Wow. But the woman has been taking it on her own, has never had any complication, has never had any miscarriage and all that, but she has PCOS. So that's why we call it ovulatory PCOS. Yes, these are the ones that you discover incidentally. You're just scanning the woman for a different thing and realize she has multiple polycystic ovaries that are seen in PCOS. So that's the ovulatory type. Okay. Then the last one is the androgenic type. The androgenic type, these ones have the male hormone level, they have irregular menses, but they don't have polycystic ovaries. Okay. Which means these are the ones that you go to ultrasound, you check, you won't see cysts in their ovary, but they have irregular menses and they have high male hormone level, making it remember classical PCOS, hyperandrogenic type, non-hyperandrogenic type, and the ovulatory type.
Okay.
Yes.
Okay. So thank you very much.
So anytime you suspect that you have this problem, this diagnosis is made by any doctor, anywhere, any day. You as a patient should try as much as possible to find out from your healthcare provider which phenotypic type do I have, so that because the treatment will not depend on the type you have. For instance, you can see that the ovulatory type, they don't have problem with ovulation. They achieve pregnancy spontaneously and carry their pregnancy to term and deliver without any problem. You only discover that they have this thing maybe because you're scanning them for a different thing altogether. You might even just be scanning to see how their baby is lying, and then you realize that their ovaries are, so they don't have such problem. So for them, the problem is not there.
Yes.
Okay. However, all of them are at risk of the long-term complication. Because
yes, I wanted to ask you that if you have, let's say you have PCOS or having PCOS, is there anything, if you don't manage, is there any complication of having PCOS, like
sure.
Even if you give birth to your baby and then you have PCOS, is there anything to worry about?
Sure, yes.
Oh, okay.
When you have PCOS, you are at risk of two major sets of complications: short-term complications and long-term complications. Now, the short-term complications are one, irregular menses. Of course, they have problems. You see a lot of women coming to tell you, doctor, my menses is not regular, and you tell them that this is PCOS. They say, okay, please help me correct it. For them, that is a problem. The second problem is delayed conception or infertility. And somebody will come to you and say that, doctor, we can't, I've been trying for the past 1 year, 2 years to take it, and I'm not taking it. What is wrong with me? And you check the woman and realize that her problem is PCOS. And you tell her that, look at the problem. And she tells you, what can you do to help me? So for them, that is the second complication. Now, the third complication is recurrent miscarriages. I have seen a woman that have 7 consecutive miscarriages, means 7 pregnancies in sequence, all of them aborted in the first trimester, only for us to check and realize that she has PCOS, high elevated level of hyperinsulinemia, and that is what is aborting her baby, and she didn't know that.
Which is very manageable.
Yes, which is manageable, but it's a complication. All these are short term. Another one is preterm delivery, because these women too are at risk of preterm delivery.
What's preterm
delivery? Preterm means delivery before 9 months. Oh. When a woman delivers her baby before 9 months, the shorter the gestational, the age of the pregnancy, the higher the babies are at risk of dying. So babies are supposed to be delivered at 9 months. But PCOS patients, when they take in either spontaneously or artificially, they are at risk of giving birth before them. So that's why they need to be managed in long-term complications, like I said before, are the complications that everybody that has PCOS is at risk of developing these long-term complications. And these are the reason why they need to be closer to their medical doctor as they age, because these complications can arise. What are they? One is overweight and obesity. Obesity is a disease. Any woman that has a body mass index that is more than 30 and above is obese. And obesity on itself is a disease. So the second point is endometrial hyperplasia. Endometrial hyperplasia simply means the overgrowth of the inner lining of the womb as a result of no ovulation. When a woman is not ovulating, she's not menstruating regularly. So the inner lining of the womb can overgrow in a condition called endometrial hyperplasia. And if not treated, endometrial hyperplasia can predispose the woman to endometrial cancer. Ooh. Yes, this condition can actually predispose you to developing cancer of the endometrium. Yes, that is the reason why you must come to the doctor, and your menses must be induced at least once every 3 months to 6 months in order to ensure that the inner lining of your womb is clean, is shared and is clean. Yes. The third one is metabolic syndrome or metabolic derangement, such as diabetes. Especially gestational diabetes mellitus. What that means is the diabetes mellitus that is diagnosed in pregnancy only. Yes, these women are at risk of developing it. It's called GDM. The second one is that they are at risk of developing type 2 diabetes later in life. Yes, at later age, they can develop type 2, which is the non-insulin dependent diabetes mellitus. The other ones are things that have to do with high fat and cholesterol levels, such as atherosclerosis, the risk of hypertension, and then atherosclerosis can predispose you to the risk of developing coronary heart diseases, such as angina pectoris, myocardial infarctions, and so on, heart failure, even cardiac arrest, and all that can happen to these women with time. So it is because of these long-term complications that they need to see the doctor from time.
This is very interesting, guys. Yeah. So you can see PCOS. You might have given birth, or you've been diagnosed with PCOS, and because you gave birth successfully, you relax, thinking that there's no problem, there's no need for seeing your doctor. Now, Dr. Henry here has pointed out complications. He pointed out the short-term and the long-term complication. The long-term complication, which is endometrial cancer, he has explained how it comes about. High cholesterol. Henry, thank you very much. Let's talk about the last one, which is management of PCOS. So Dr. Henry, please, can you tell us about management of PCOS? Like if someone has PCOS, how can it be managed? And of course, prevention, of course, if there is any way it can be prevented. Thank you.
So the first thing I want to say is that if any doctor diagnoses PCOS in a woman, that woman must immediately see a specialist, a gynecologist, to get proper advice on how to manage it.
Okay.
The management involves two different segments. The first one is the general management, and the other one is specific management. Okay. The general management applies to everybody, and that includes things like regular exercise, weight reduction, and other lifestyle modifications, such as, you know, if you smoke, you should stop. If you take alcohol, you should stop. If you live a very quiet, sedentary lifestyle, you should start living an active lifestyle that will help you to exercise, lose weight, and remain healthy. Okay? These two is, in fact, weight loss alone can restore somebody's menstruation and ovulation. If you can lose up to 10% of the weight that you have at the time the diagnosis is made. Yes, research has shown that if you can lose up to 10% and above, spontaneous return of your sexual menses and ovulation can come back, and you can take it without even further medication. Then the specific management will now depend on the type, the phenotype. Remember, I mentioned before, yes. For those that are having irregular menses, we can regularize their menses using combined oral contraceptive pills. For those that are having difficulty in conception as a result of no ovulation, we can induce ovulation using ovulation induction agents. For those that are having problems with the recurrent miscarriages, abortion and all that, we can now register them early in pregnancy and begin to control both their blood sugar and also monitor the pregnancy to ensure that the risk of that spontaneous abortion is reduced and the pregnancy is carried to term. For those that their problem is recurrent preterm labor, they deliver before time. You understand? We now manage them and also, you know, monitor them closely to ensure that it does not happen. And even if it happens, they receive the needed help that they need in order to ensure that their term and their babies survive. Exactly. So for those that we discover too that have endometrial hyperplasia, I mentioned, that's one factor that can lead to endometrial cancer. We do what they call endometrial curettage and send the sample to the histology. The histology will now check and let us know whether there is cancer there or not. If there is no cancer, we tell them what to do to prevent it from happening again. And if there is cancer, we also manage it because it's within our jurisdiction. Then for the long-term complications, if you manage the short-term, very well, or if you do what you're supposed to do in the short term, majority of the long-term complications will be reduced if not prevented. Yes, but